panelist. Yes. Tetracyclines, yes, correct. Tetracyclines, it is discolored. Fine. Good Varsha, good Archita. Nice. So lithium, it is not neural tube defects. It is going to cause Epstein anomaly. And warfarin, anyone? Can anyone tell me which drug causes aplasia cutis? It is penicillamine. It is penicillamine. So this teratogenic effects again at most important topic in INI. Teratogenic effects is at most important topic in INI. Let's see now what are all the drugs which are present and their teratogenic effects quickly. So let's see thalidomide, phocomelia, and tetracyclines. It is going to cause bone and teeth abnormalities. Bone and teeth abnormalities. Diethyl stilbestrol, it is going to cause clear cell adenocarcinoma. And the next one, isotretinoin, it is going to cause craniofacial cardiac abnormalities. Next, AC inhibitors, that is PRILs, and ARBs, that is sartans, they are going to cause renal hypoplasia. Renal hypoplasia. Next, methimazole, it is going to cause aplasia cutis. And of course, tracheoesophageal fistula. Next, lithium asked multiple times in the exam. Epstein anomaly. Epstein anomaly. There is nothing but tricuspid wall defect. Next, phenytoin, cleft lip and cleft palate. Characteristic things. Valproate, neural tube defects. Next, warfarin, it is going to cause flat nasal bridge and a stippled epiphysis. Stippled epiphysis. Next, penicillamine, it is going to cause cutis laxa syndrome. Cutis laxa syndrome. So here, this everything is asked in the exam. Each and everything is asked in the exam. Thalidomide asked, tetracyclines, AC inhibitors, methimazole, lithium, phenytoin, valproate, warfarin, everything is asked in the exam. So that is the reason why I have given this kind of matched one, and I have given the entire teratogenic effect of the drugs. Each and every drug is important, and he will be asking what pregnant woman she might have taken some drug and what abnormality you can see in the fetus. So that's all about this teratogenic effect. Again, at most important one. Now come to the third question. Here you see a 50-year-old man with a decompensated chronic liver disease developed acute agitation and started on benzodiazepine. Which of the following benzodiazepines most appropriate in this patient? Anyone? So benzodiazepines, liver failure, which one? Nice. Lots, fantastic. Savarish, lots, less fantastic. And again, this is a question asked multiple times in the exam. I told you multiple times. The benzodiazepines which are safe in liver failure, which are safe in liver failure, that is lots. Lorazepam, oxazepam, timazepam, and estazolam. And that is estazolam. So here we have oxazepam. That is the correct answer. The same question he will twist in other way. He will give the same thing and he will ask which are the following benzodiazepine which we cannot use. And he will give out of these four, he will give three and one might be diazepam. So which we cannot use is except these. These are the things which we can use, and except these four, anything we cannot use. So read question very carefully what he is asking, whether he's asking which we can use or which we cannot use. So that's all. Again, a most important one. Benzodiazepine safe in the liver failure. That's all. And now come to the fourth question. Again, so here, which are the following characteristic features? Characteristic feature of phase one biotransformation reaction. He has asked about phase one. Read question carefully whether he's asking with phase one or phase two. So he has asked like phase one. So here it's like yes, correct. They involve oxidation, reduction, hydrolysis. Yes, this is what the correct answer. Then what about these three? So before going to these three, let's see what are these biotransformation reactions. Like quickly we'll go through. So biotransformation, it is divided into phase one reactions and phase two reactions. Phase one, which is also known as degradative or non-synthetic. That means degradative means we are breaking it down. And phase two, they are conjugative or also known as synthetic reaction. Conjugative or synthetic reaction. So what's happening here? What will be the status of this final product? Here it might be either water soluble or lipid soluble, either ionized or non-ionized, either polar or non-polar. In phase one, it might be anything. But in phase two, I told you it is like VIP. It's like V means like water. It is water soluble and it is ionized and it is polar. It is easy for elimination. And what are the examples? Here already we have done oxidation, reduction, and hydrolysis. These are the examples of phase one. And coming to phase two, glucuronide conjugation, glutathione conjugation, sulfate conjugation, water conjugation. There are so many things, water conjugation. But if you can remember, if you cannot remember these, at least if you can remember these things comes under phase one, all the remaining things comes under phase two. That is enough. But here you should carefully identify these terminologies. Now let's come to the question here once again. They convert drugs only into lipid soluble forms. So no, not only lipid, either water soluble or lipid. So this is not a correct one. Involve conjugation of drugs. No, conjugation of drugs is involved by phase two. Also known as synthetic reactions. No, they are also known as degradative or non-synthetic. All these three, the remaining two, three, four are characteristics of phase two. This is what the direct question came in a lot called INI-CET 2024. So that's all about this phase one reaction. Read question carefully whether it's asking phase one or phase two. And one more thing, read which of the following is a characteristic feature or which of the following is a not a characteristic feature. Those are the question seems to be easy, but what you call answer seems to be easy, but question he will twist little bit. So read question very carefully when you are answering. So that's all about this question. Now come to the next one. Here you see a 30-year-old woman with a tuberculosis is being treated with rifampicin. She's also taking OC pills for birth control. Which of the following most likely the consequence of the drug interaction? Quickly, anyone? What's happening here? Subhashini is saying one. Yes, yes, it's two. That's what. No, Varsha, it's not one, it's two, it's two. See, that's the beauty of INI. Here, everyone knows there is a decreased effectiveness of OC pills. So immediately after reading this term, decreased effectiveness of OC pills, without reading two, three, four, what we will do, we will blindly go for one. But if you can see here, it is due to enzyme inhibition. No, it is not due to enzyme inhibition. It is due to enzyme induction. That's where these INI paper, what you call, they twist the options. Immediately after seeing this one, we'll go for option one. That's why I always tell, even if you know the answer, just read the remaining options too. Yes, yes, Subhashini. So here it's like option two, decreased effectiveness of OC pills. It is due to enzyme induction. Enzyme induction, it's not as fantastic, fantastic. No, the pricing service, okay, that's fantastic. So again, a very, very, very important one, these enzyme induction, enzyme inhibition. A very important concept it is. Just we'll see what's happening in enzyme induction. Enzyme induction, what is going to happen? It is going to decrease the efficacy. And enzyme inhibition, what is going to happen in enzyme inhibition? It is going to increase the toxicity. It is going to increase the toxicity. So now, what are all the examples here? Enzyme induction, enzyme inhibition, what are all the examples? This already we have done. Pricing, service. Okay, this is what I told, right? So now let's see one by one. P, phenytoin, and RI, rifampicin. This is what here, rifampicin, in the question we have got. Rifampicin is an enzyme inducer. C, carbamazepine, and as well as cigarette smoking. I, isoniazid, N, nevirapine, and G, griseofulvin. These are all enzyme inducers. If you combine these drugs with any other drug leading to decreased efficacy. Next, what about enzyme inhibitors? It is like service, okay. Yes, it is nothing but SSRI, E, erythromycin, R, ritonavir, V, verapamil, and one more V, valproate. Next, one more I, isoniazid here again. Here also we have isoniazid. Here also we have isoniazid. Here it is going to stimulate CYP to E1. Here it is going to inhibit CYP3A4. Next, C, ciprofloxacin. And one more C, clarithromycin. And multiple times the question was asked about this clarithromycin, including recent INI. So he will combine clarithromycin with some other drug, leading to what? Leading to increased toxicity. So mostly he'll be asking either phenytoin, rifampicin, or clarithromycin. 99% these three drugs he will ask. And then one more E, again it is erythromycin. For our convenience, we have made this one. And then next O, omeprazole, and K, ketoconazole. That's all. That's all about enzyme inducers, inhibitors. Read question very carefully whether he's asking enzyme induction part or enzyme inhibition part. So if you see any two drugs combination, 99% he'll be asking about this concept, enzyme induction and enzyme inhibition. So that's all about these enzyme inducers and enzyme inhibitors. Now come to the next question. So now again, loading dose. The calculation of loading dose is primarily governed by which of the following parameters? Anyone quickly in the chat box? Yes, yes, yes. Fantastic, fantastic. Nice. So already I told you loading dose, maintenance dose. I told you one simple thing. It's like love MCH, loading dose, volume of distribution, maintenance dose. It is depends on clearance and half-life. H means half-life. I told you multiple times. So loading dose, volume of distribution, clearance and half-life, it is for maintenance dose. Remember this one, love MCH, ask for multiple times in the exam. Ask for multiple times in the exam. Read question carefully whether he's asking loading dose or maintenance dose. Maintenance dose. So just remember love MCH. That's all. That's all about this loading dose and maintenance dose part. Now come to the next one. Again, the same question asked, like it's like they have given a picture and they have given a what you call descriptive part also. So it's a Lineweaver-Burk plot, and this is what he has given, and what type of enzyme inhibition is it? Hmm, anyone? Yes, yes, yes. Darsh, it is correct. Yes, it's three, it's three, it's three. Yes, yes, it's three, it's three. Fantastic. Here you see, I told you, like, even if you don't know anything about Lineweaver-Burk plot, just from seeing the graph, very easily we can tell. Now, let's see, these are the three Lineweaver-Burk plots we have. Of course, you might have read in biochemistry too. Here you see, if two things are crossing against each other, if two things are crossing against each other, that means they're crossing against each other, it is nothing but competitive antagonism. What competitive, sir? It is reversible competitive. When two things are crossing against each other, it is like without inhibitor, and this line is with inhibitor. If they are crossing, that is competitive. If they are not, that means if they are crossing at y-axis. No, if they are meeting on x-axis, then it is also competitive antagonism, but it is here it is reversible. Here it is irreversible. Irreversible competitive antagonism and as well as non-competitive antagonism. If they're not at all crossing, if they're parallel, then it is uncompetitive. Very simple. If they are parallel, uncompetitive, if they are meeting on y-axis, then it is competitive. If they are meeting on x-axis, then they are non-competitive or competitive irreversible. Here it is they are meeting on y-axis, here they are meeting on x-axis, here they are not at all meeting, just they are parallel. Here you see, here they are just parallel. So it is like uncompetitive. uncompetitive. Very simple one, very important. Even if you don't know anything, you don't know anything about KM, you don't know anything about Vmax, just by identifying, just by seeing the graph, it is very easy to tell. So that's all about this antagonism part. There are three types of antagonism, and that's how we can identify. That's how we can identify. Now come to the next one again. Trust me, in the coming INI, the things which I'm going to discuss now, antidotes, one or two questions, one minimum question, and max like two questions, definitely it will be there. Minimum at least one question will be there about antidotes. Here you see, so he has asked antidotal therapy, he has asked antidotes. Here, former emergency department, excessive salivation, sweating, pinpoint pupils, muscle fasciculations, and confusion. So classically, I told if you see former pinpoint pupils and excessive salivation, it is classically OP compound poisoning. So what is antidote? That is fantastic, pralidoxim and atropine. Pralidoxim and atropine, fantastic. So now let's see the all the antidotes which are present. Trust me, in these coming two slides, one question or mostly in the last what you call four exams, he is asking about match the following. Definitely one question will be there. Now let's see one by one. Acetaminophen, N-acetylcysteine, that is paracetamol, aspirin and tricyclic antidepressants, IV sodium bicarbonate, OP compound poisoning, atropine, and pralidoxim we can give. Next, carbamide poisoning, only atropine, no pralidoxim. Atropine poisoning. Can anyone tell me, is it physostigmine or pyridostigmine? Physo, fantastic. Physostigmine. Fantastic, fantastic. Physostigmine. Malignant hyperthermia, dantrolene, benzodiazepine poisoning, flumazenil, alcohol, fomepizole. Don't get confused between flumazenil and fomepizole. Yes, yes, very good, Sabarish. Pyridostigmine for myasthenia gravis. Don't get confused between these two. If you shake alcohol, you will get foam. You will get foam. Beta blockers, fantastic. Glucagon. Yes, generally it's glucagon. Methotrexate, folinic acid. Don't get confused. He will give folic acid in the options. Don't get confused. Don't get confused. Next, bupivacaine, intralipid emulsion, intralipid emulsion. Each and everything is asked in the exam. Each and everything is asked in the exam. STBI, it is folinic acid. Next, opioid poisoning, naloxone, and heparin, protamine, and dabigatran, idarucizumab, factor 10A inhibitors, xanet alpha, foreign, vitamin K, iron overload. Iron overload, anyone? Desferoxamine. Yes, yes, desferoxamine. Deferoxamine, anything is fine. Desferoxamine, deferoxamine, anything is fine. And doxorubicin induced cardiotoxicity, dexrazoxane, cyanide poisoning, hydroxocobalamine, digoxin. There is something known as digibine, which is only FAB fragment, digoxin antibody, that is digibine, that is FAB. And don't get confused here. It has only one fragment, that is FAB. There is no FC fragment. Serotonin, cyproheptadine, methemoglobinemia, methylene blue. These are all the antidotes. These are all the antidotes. Trust me, one question it is damn sure in the coming INI, in the coming INI about these antidotes. That's what we are discussing in the last page of our workbook. That's all about these, all the antidotes. So that's all about this OP compound poisoning antidote, that is pralidoxim and atropine. That is what I mentioned here. That is what I mentioned here. Now come to the next one. Which of the following reversible anticholinesterases is useful in antidote of atropine toxicity? Just now we have discussed it. That is nothing but physostigmine. That is fantastic. Physostigmine. Again, everything is important here. So now let's see here what are the other uses of this. So we know acetylcholine with the help of acetylcholine esterase, it gets converts to its metabolites. And I am giving few drugs which will inhibit this acetylcholinesterase so that it is going to increase the acetylcholine level. So all these are reversible. These are reversible acetylcholinesterase inhibitors. Now let's see one by one. Edrophonium. It is useful for diagnosis of myasthenia gravis. It is used for diagnosis of myasthenia gravis. So how, sir? So now let's see a muscle weakness patient came. That muscle weakness patient came to you, emergency department, and you don't know whether it is due to myasthenia gravis or cholinergic crisis. Give edrophonium. If muscle weakness improves, then it is myasthenia gravis. If muscle weakness worsens, then that is cholinergic crisis. Cholinergic crisis. That's all about this myasthenia gravis part or like muscle weakness part, and this is also a question asked in the exam. He will give the situation and he will tell whether it is improved or whether it is worsened, and based on that we can go for diagnosis. Why only hydrophoniums, or why can't we use other things? Because it has short half-life. That is the reason. This is also a question asked in the exam. Short half-life. That is also a question asked. Next, physostigmine, we know that is atropine poisoning. Pyrido, that's what I told you. Myasthenia gravis. Don't get confused between physostigmine and pyridostigmine. Myasthenia gravis, second letter is Y. Pyridostigmine, second letter is Y. Right. Next, neostigmine. It is also useful in the treatment of myasthenia gravis and as well as neuromuscular blocker reversal agent. Neuromuscular blocker reversal agent. Neuromuscular blocker reversal agent. That's all. It's a reversal of muscle relaxation. That is fantastic. That's all about these reversible anticoagulant. Each and everything is asked in the exam. Can anyone tell me something about Sugammadex? It is useful for reversal of fantastic rocuronium and vecuronium. Rocuronium and vecuronium. Sugammadex useful for rocuronium and vecuronium. Again, this is also a question asked in the exam. That is also a question asked in the exam. That's all. That's all about these reversible anticholinesterases. Reversible anticholinesterases. Now come to the next one. Again, this is also multiple times they have asked in the exam. Beta 2 agonist, what is its effects on potassium and glucose? See questions carefully and then answer. Janani, yes, they're saying 3, Shabari is 3, Ilakia 3, that's fine. Pranita 3, the 3, yes, it's 3, it's 3. Yes. Already I told you it is going to decrease the potassium, it is going to increase the glucose. See questions, see options carefully when you're attempting such kind of questions, hypo and hyper. Subject might be anything in those 200 questions, whether if they give such kind of terminologies like hypo and hyper, read question carefully. So beta diagonal, this already I told you. If you can remember, I told you one mnemonic that is kiss emoji, right? Kiss emoji. So potassium inside a cell. So kiss means potassium. Potassium. We are sending inside. We are sending inside. This is a cell inside, and this is outside. So we are sending potassium inside. What are the two things? One is E, that is epinephrine, and then I, that is insulin. E means epinephrine, and I means insulin. So both epinephrine and insulin, they send potassium to inside. That means they both cause hypokalemia. But how they are sending, that is what important here. Via beta 2 agonist, epinephrine sends, and via sodium potassium ATPase, insulin sends. So that's all. So this is what I told. The effect is same, the action is different. So Beta 2 agonist, it is going to cause hypokalemia. So epinephrine and insulin, they both cause hypokalemia. How? Epinephrine via beta 2 agonism and via insulin via sodium potassium ATPase. Read question carefully what he is asking, and this is what the reason. This is what the reason behind it. That's all. That's all about this part, hypokalemia and hyperglycemia. That's all about beta 2 agonist part. Now come to next one. Which of the following actions of opioids does not develop tolerance? Does not develop tolerance over the time. Does not develop tolerance over the time. Yes, yes, yes. It's meiosis. Meiosis. Yes, fantastic, fantastic. It's meiosis. So does not develop tolerance. I told you single best answer, meiosis. If you give multiple things, then first to give up clear option, preference to meiosis. Next to go for case. What is this one? C, constipation. And one more C, convulsions. A, analgesia, sedation, and MSS. First preference to always meiosis. That's what meiosis. Meiosis does not develop tolerance. But if I ask you, quickly tolerance develops to, quick tolerance develops to anyone? It's euphoria. Rapid tolerance to euphoria. So what type of tolerance it is? Pharmacodynamic tolerance compared to pharmacokinetic tolerance. Pharmacodynamic tolerance compared to pharmacokinetic tolerance. Can anyone tell me how to prevent this tolerance? Prevention of opioid tolerance, anyone? How to prevent this opioid tolerance? We can give one drug, ketamine. Fantastic, 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 ketamine. A very important one, this tolerance part. We have done everything about this tolerance. We have done everything about this opioid tolerance. Fantastic, no, fantastic. That's all. It's not a methadone, Pranita. It's not methadone. Methadone is useful for withdrawal. Withdrawal, treatment of withdrawal, opioid withdrawal treatment, we go for methadone and buprenorphine. So tolerance, that is ketamine. Tolerance, that is ketamine. Clear, ma, Pranita? So that's all. That's all about this part. Now come to the next one, opioid antagonist. Opioid antagonists available in long-acting injectable form for the treatment of opioid and alcohol dependence for both. For both. Yes, yes, it's naltrexone. That is, it's not naloxone, Swatika. It's naltrexone. It's naltrexone. Naltrexone. Don't get confused. Both opioid and alcohol dependence. I'm not asking about opioid poisoning. I'm asking about opioid and alcohol dependence. So that is naltrexone. Again, utmost important for INI. INI, opioids, and anti-epileptics, antipsychotics. These three topics are utmost favorite to INI, what you call exam paper setters. Now let's see. These are all the opioid antagonists. The first one, naloxone, naltrexone, methyl naltrexone, and alvimopan. Each and everything is asked in the exam. Naloxone, it is one that it is short acting and orally it is inactive. That is the reason why we give IV. So indication that is for opioid poisoning. Naloxone, opioid poisoning, antidote. That's already we have done. Naltrexone, it is a long acting one which is orally active. It is useful in opioid dependence, that is opioid use disorder, and alcohol use disorder. Naltrexone, it is used for opioid and as well as alcohol use disorder. Next, methyl naltrexone. It is used in opioid-induced constipation. Opioid-induced constipation. Next, albumin. This already I have told you. If you can remember, it is an antagonist. What antagonist? Opioid antagonist. Opioid antagonist. So it is a mu opioid antagonist useful in the treatment of ileus. Useful in the treatment of ileus. So it is used in the treatment of post-operative paralytic ileus. Post-operative paralytic ileus. That's all. That's all about this opioid antagonist. Fantastic, fantastic, no? Nice. So that's all about this naloxone, naltrexone, methyl naltrexone, and albumin. A very important one. Like opioid antagonists and their characteristic uses. Characteristic uses. That's all, nothing much. That's all, nothing much. That's all about opioids part. Now come to the next one. Again, it's during the recent INI again, which are the following anti-epileptic drugs act by enhancing the slow inactivation of voltage-gated sodium channels. Voltage-gated sodium channels. 3 years, years, still. Read question carefully. He has asked voltage-gated sodium channels, but it is slow. He has asked about slow inactivation. Slow inactivation. So slow inactivation means that is lacosamide. That is lac. Read question carefully whether it's asking slow or fast. Whether it's asking slow or fast. And now here comes a very important one. Anti-epileptic drugs mechanism of action. It's not one number SVVS. That's what I told you. That's the reason why I kept the first option. Phenytoin is a fast inactivation. Fast inactivation. See that. See here. These are all the drugs. These are all the drugs. Sodium channel modulators. Fast inactivation. Phenytoin, carbamazepine and its analogs, valproate, lamotrigine, felbamate, topiramate. They all comes and fall. There are many drugs. Many drugs. Obviously, he's not going to ask those many drugs. And this is what a very important slow inactivation. Slow inactivation, what drugs we have? Lacosamide and then rufinamide. Lacosamide and rufinamide are very important. Trust me, might be in the coming exam, in the coming, what you call 50, 55 days. One question from the coming at least 3 or 4 topics which are going to discuss now, including opioids. Definitely one question will be there. 1 or 2 questions definitely will be there. And alpha 2 delta ligands, it is nothing but gabapentin and pregabalin, and GABA transaminase inhibitor, that is vigabatrin. Next, GABA transport inhibitor, that is tiagabin. This is what I told you, vigabatrin. Here you see from the name itself, GABA transaminase inhibitor. That is what I told you here, GABA transaminase inhibitor. Next, tiagabin, it is transport inhibitor. Tiagabin, GABA transport inhibitor. Transport inhibitor. Next, SV2A protein ligand, that is levetiracetam. Levetiracetam and brivaracetam. Levetiracetam and brivaracetam. And AMPA. Here you see parampanel. The name itself has AMPA. Parampanel. AMPA. Right? Next, NMDA antagonist felbamate increases HCN channel. That is nothing but lamotrigine. Of course, lamotrigine has multiple mechanisms. Characteristic one. Potassium channel. Potassium channel allosteric modulator izogabin. Izogabin also known as retigabin. Very important, this mechanism of action. Very important. Read question carefully whether he is asking fast inactivation or slow inactivation, whether he is asking GABA transaminase inhibitor or GABA transport inhibitor. So read question carefully because these are the confusing things. As already I told you, examiner loves your confusion. Examiner loves your confusion. That's all about these anti-epileptic drugs mechanism of action. There are 3 most important anti-epileptic drugs which we need to discuss. We'll discuss one by one. Here, that one more question here. A 6-month